Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues, we are discussing management of chronic hepatitis B in the light of uh, practice guidelines. In this regard, we discussed 6 clinical scenarios initially, and then we started reviewing the salient features of the available guidelines. In today's session, we shall discuss the treatment of chronic hepatitis B. We shall see when to start treatment, what are the treatment options, how to monitor the antiviral therapy, and when to stop this treatment. In this regard, in the treatment of chronic hepatitis B, I recommend the EASL 2017 clinical practice guidelines on the management of hepatitis B virus infection. These are very simple, practical, and very much concise. Before starting a discussion on the treatment of hepatitis B, I'll give a reference of hepatitis C, which is a cytoplasmic disease. The virus lies within the cytoplasm of the hepatocytes. Hepatitis C is a curable disease, and once a patient is found to be having hepatitis C, you start antiviral treatment unless it is contraindicated. And there is a defined duration of antiviral treatment. Why I wanted to give reference to the hepatitis C, this is very important that in clinical practice, most of the times the caring persons or the clinical practitioner, they mix or they confuse hepatitis B with the hepatitis C, and they treat their hepatitis B patients on the lines of hepatitis C. Hepatitis B, it's a nucleic disease. It's not a cytoplasmic disease because the cccDNA lies within the nucleus of the hepatocytes. Therefore, it's a lifelong disease. The HCV is just like an infection, but hepatitis B becomes a lifelong disease, just like diabetes, just like hypertension, just like epilepsy, just like asthma. Hepatitis C is a curable disease. You can eradicate the hepatocytes from the HCV, whereas as compared to this, the hepatitis B is only controllable. You control the disease with the help of the therapy. You cannot eradicate the hepatitis B virus. You cannot remove, you cannot clear, you cannot clean the hepatocytes from the hepatitis B virus. In hepatitis C, I said you start antiviral treatment unless it is contraindicated. Here it is reversed. You start treatment only when it is indicated. So you don't start treatment in each and every patient. You start only when it is indicated. And as I said, the HCV is a defined duration of antiviral treatment. The hepatitis B has got a lifelong antiviral treatment. When to treat? The answer of this question lies in 4 aspects. Are to answer or to be able to start the patient on treatment, you need information regarding the 4 main parameters. One is the liver status of the patient. Second is the viral load of the patient. Third is the serum ALT levels. And fourth is the other risk factors. So the first factor which decides whether you should treat a patient or not is the liver status. If the liver status is not answering your questions whether the patient needs treatment or not, then you go for the viral load. And when viral load cannot help you, then comes the role of serum ALT levels. And when all these things, the liver status, viral load, serum ALT level, when they cannot give the clear answers that whether the patient should be started on antiviral treatment or not, then the other risk factors comes into play. I'll explain this 4-step strategy in the coming slides. The liver status, we know that the liver status has got three main phases. One is the liver without fibrosis, second is a fibrotic liver, and third is a cirrhotic liver. And how we decide that a liver of this patient is without fibrosis, or it's a cirrhotic liver, or it's a fibrotic liver, it depends upon five main parameters. The very first parameter is that of clinical features of liver cirrhosis. And then we take the help of the ultrasound, then the EPRI, FIB4, and the FibroScan. So when a patient with chronic hepatitis B is sitting in front of us, we look for we ask the history of hepatic encephalopathy, we ask the history about any variceal bleed, and we examine the patients for ascites. If the patient has presented with hepatic encephalopathy, or if the patient has presented with variceal bleed, or if the patient has presented with ascites, it is a cirrhotic liver. So the absence of hepatic encephalopathy, variceal bleeding, or varices, and ascites at present, and no past history of these complications is mandatory to say that the patient liver has got no fibrosis. Then the ultrasound in a normal liver will be reported as normal. The EPRI and FIB4, they will be less than 0.5 and less than 1.5, and the FibroScan will be having less than 7.5 values. When the patient meets these criteria, no clinical features of cirrhosis, normal ultrasound, and EPRI, FIB, and FibroScan values below these, then we label that this patient's liver is without fibrosis. What about fibrotic liver? In fibrotic liver, again, there will be no history of hepatic encephalopathy, varices, or ascites. The ultrasound will be reported normal in all these phases. And we know that the fibrotic liver may be having F1 fibrosis, F2 fibrosis, or F3 fibrosis. So the EPRI values will be from 0.5 to 1.5. The FIB4 value will be from 1.5 to 3.5, and the FibroScan values will be from 7.6 to 12.5. When the patients meet this criteria, then we label this patient's liver as a fibrotic liver. And then comes the cirrhotic liver, and the cirrhotic liver is when there is a history of hepatic encephalopathy, bleeding varices, or ascites in present or past, and the ultrasound in such patients shows small and shrunken liver, splenomegaly, dilated portal vein, and ascites with or without ascites. And when we look for the EPRI, it's more than 1.5, FIB4 is more than 3.5, and FibroScan value is more than 12.5. When this criteria is fulfilled, then we label this patient as cirrhotic liver. So, regarding the liver status, we decide whether the patient's liver is normal or fibrotic or cirrhotic with the help of the clinical features, ultrasound, EPRI, FIB4, and FibroScan. Let's proceed further. So, if a patient is cirrhotic liver, if a patient lies in this category, cirrhotic liver, there are clinical features of cirrhosis, or ultrasound is showing features of cirrhosis, or EPRI, FIB, and FibroScan values fulfill this criteria. In this fibrotic liver, any detectable level of hepatitis D DNA and any level of ALT, this qualifies a patient to be started on antiviral treatment. What about fibrotic liver? This is the fibrotic liver. No clinical features of cirrhosis, ultrasound is normal, but the EPRI, FIB4, and FibroScan values are this one. Here, you need viral load to be more than 2000, and ALT to be raised, any level of raised ALT. When a patient fulfills this criteria that the ALT is raised, hepatitis B virus DNA is more than 2000, then you start these patients on antiviral treatment. If a patient has got normal liver lying over here, then you need both the parameters. The DNA level should be more than 2000, of course, but the ALT should be more than 2 times normal. When this is present, then you start the patient on antiviral treatment. So with the more liver is damaged, low is the threshold for the viral load as well as for the ALT levels. And when there is no fibrosis, normal liver, the ALT level is high, as well as the ALT, the viral load level is also high. What about fibrotic and normal liver when the ALT is normal? Can we do something, or we should just wait and see? In this regard, the EASL guideline says that if a patient age is more than 30 years in this group, and there is a family history of HCC or cirrhosis, or there is extrahepatic manifestations, then you start these patients on treatment. What about the DNA level, low level viremia when it's more than 2000? Either the patient has got fibrotic liver or normal liver. Then comes the AACD guidelines into play, and this is called low level viremia. So you treat if the quantitative HbS antigen titers are more than 1000, but if these are less than 1000, then you don't treat, just follow up these patients. This is the way we take the help of guidelines in deciding when to start treatment. What drugs are available? We all know it's pegylated interferon, alpha-2A and alpha-2B. Alpha-2A has been used for the treatment of hepatitis B. Then the oral drugs, nucleoside analogs and nucleotide analogs. And the nucleoside analogs, the lamivudine and tilbivudine are now out of fashion, out of clinical practice. This is the entecavir, which is being used nowadays. This is the drug with high barrier resistance. And the nucleotide analogs, edifovir is out of clinical practice. This is now the tenofovir, disoproxil fumarate, TDF, and tenofovir alafenamide, which are being used in the treatment of chronic hepatitis B patients. Every drug, the pegylated interferon and the oral drugs, they have got advantages and disadvantages. The advantages of the pegylated interferon were that they are needed for finite duration of treatment, no antiviral resistance, they give you sustained response, and they give you better HbS antigen seroconversion. But they had got some disadvantages, and these disadvantages are that frequent adverse events are associated with pegylated interferon. They are injections route. They have got less HBV DNA suppression, and they are expensive therapies and not safe in advanced disease. As compared to the pegylated interferon, the nucleoside or nucleotide analogs have got the disadvantage. The advantage is that they have got less adverse events. They have got the oral route. They have got the greater HBV DNA suppression. They are less expensive, and they are safe in advanced diseases. While their disadvantages are that these oral drugs they need to be given for the infinite duration. There's a risk of resistance, but with the latest drugs, the resistance is very, very low. They give you maintained response, and they have got less HbS antigen seroconversion capabilities. So if we see the advantages of the pegylated interferon, they are when becomes the disadvantages when these are the disadvantages of the orals, and the advantages of the oral are the disadvantages of the pegylated interferon. That's the comparison between these two sorts of therapies. Which drug to prescribe? Pegylated interferon alpha, its mechanism is that it causes induction of a long-term immune control. It is given for 48 weeks therapies. Level of viral suppression is moderate. Effect on the HBe antigen loss is moderate. Effect on the HBs antigen level is variable. Risk of viral resistance is not there. Risk of relapse after treatment cessation is low for those with sustained response 6 to 12 months after the therapy. Route of administration is subcutaneous injections, and tolerability is low, and long-term safety concern is very rarely persistence of the on-treatment adverse side effects, and contraindications are many, and risk of viral resistance is not. What about the entecavir TDF and TF? The mechanism is that they cause inhibition of the viral replication. Treatment duration is long-term until HBs antigen loss, and practical purposes, these are given lifelong. The level of viral suppression is very high. The effect on HBe antigen loss is low in first year and then moderate over long term. The effect on the HBs antigen level is low. The risk of viral resistance is minimal to none with these three drugs. The risk of relapse after treatment cessation is moderate if consolidation treatment provided after HBe antigen seroconversion, high for HBe antigen negative disease. And the route of administration is oral, tolerability is very high, and long-term safety concerns are probably not there. There are almost no contraindications, and risk of viral resistance is minimal to none. These are the comparison of the injectable therapy with the oral therapy. Whom to give pegylated interferon? Who respond better? If a patient is HBe antigen positive, then if the patient is female with higher ALT, low viral load, genotype A or B, lower HBe antigen titers, and older age, these are the good responders for pegylated interferon. Patients with HBe antigen negative hepatitis B patients, if the patient is female, gender is female, higher ALT, low viral load, and genotype B and C are better responders than the genotype D. There are predictors of response for pegylated interferon at the week 12 and week 24, and this is the genotypes. And so if a patient is HBe antigen positive, chronic hepatitis B patients, so in genotype A, you stop, if HBs antigen, there is no decline, you stop the treatment at 12 weeks, and at 24 weeks, if the titers are more than 20,000, you stop these patients you don't give the pegylated interferon any further. If your patient is genotype B, and at 12 weeks, if the HBs antigen titers are more than 20,000, and if they remain more than 20,000 at week 24, you stop treatment. In genotype C, again, it's the 20,000 figures. If the HBs antigen titers are more than 20,000 at 12 weeks and 24 weeks, you don't give, you stop antiviral treatment, the pegylated interferon. In genotype D, if there is no decline, you can stop the treatment at week 12 if you have given for 24 weeks, and if it is more than 20,000, you stop treatment. In HBe antigen negative chronic hepatitis B patients, at week 12, you check the HBs antigen levels. Is there in any decline in the HBs antigen levels titers, you continue. But if there is no decline and it is at week 12, it is the same, then you go for the HBV DNA levels. If the HBV DNA levels, there's a 2-log decline in the viral load, you continue. But if there is less than 2-log decline in the viral load, you stop the patient's pegylated interferon, because pegylated interferon is a injectable route. It has got a lot of side effects. Therefore, and it's not give you as good response as the oral drugs are given. The only upper end of the pegylated interferon is that when it gives response it is a finite duration of therapy. So if at the week 12 or 24, depending upon the HB antigen positive or negative patients, you can decide that if you need to treat the patient's full 48 weeks therapy or you want to stop. Coming to the oral therapy, which is the preferred drug. In decompensated cirrhosis, TDF or entecavir is the preferred drug. In renal patients with renal insufficiency, TAF or entecavir with dose modification are the preferred drug. Older patients more than 60 years of age, it should be the TAF or entecavir. Bone disease, again, TAF or entecavir. In pregnant ladies, it should be TDF. TAF data on TAF safety is being published, but the guidelines still recommend the TDF. Women of childbearing age planning pregnancy in near future, AACLD says start the patient on TDF. The EASL says if no advanced fibrosis, therapy may be delayed until after infant is born. Women of childbearing age wishing to make PCR negative prior to pregnancy and TDF or pegylated interferon can be given to such patients. Previous exposure to nucleoside analogs, TAF is the option, and HIV co-infection, TDF or TAF plus emtricitabine or limivudine is the option in such cases. Few words about the oral therapy, the renal impact of entecavir versus TAF. Entecavir dose needs to be adjusted if eGFR is less than 50 ml per minute. No dose adjustments of TAF is required in adults or adolescents when the age is more than 12 years and more than 35 kg body weight, when with estimated creatinine clearance more than 15 per minute, or in patients with a creatinine clearance less than 15 per minute who are receiving hemodialysis. TAF is drug of choice in eGFR less than 60, albuminuria more than 30, low phosphates, and patients on hemodialysis. This graph tells you the median change of from baseline in eGFR over 96 weeks of TAF versus TDF. This is the TAF, and this is the TDF. In the TAF, there was no decline and it remained stable. Osteo impact of the oral therapy, entecavir versus TAF. TAF is drug of choice in chronic steroid use or use of other medications that worsen bone density when there is a history of fragility, fracture, and in case of osteoporosis. This is the median change from the baseline in BMD over 96 weeks, TAF versus TDF, the hip bones and the spine bones, and this is the TDF. It remained the same. The TAF remained the same. In the TDF, it went down. Again, the TAF was having an upper hand as compared to the TDF. What about the combination therapy? Combination therapy is generally not recommended. The nucleoside analog versus nucleotide analogs plus not recommended de novo combination therapy of two the nucleoside and nucleotides with a higher barrier to resistance, entecavir, TDF, or TAF. Drug switch or combination may be considered in treatment adherent patients with incomplete HBV suppression, reaching a plateau during entecavir or TDF or TAF long-term therapy. Then you can think about the drug switch or combination therapy. NA, the oral plus pegylated interferon, not recommended. De novo combination of NA and peg interferon is not recommended. Short-term pre-treatment with NA before pegylated interferon in treatment naive HBe antigen positive patients, again not indicated. And adding pegylated interferon, switching to pegylated interferon in patients with long-term HBV DNA suppression on NA therapy is again not recommended. What dose and duration? This is important. If the patient's liver is normal, entecavir is given in the 0.5 milligram, TDF 300 milligram, TAF 25 milligram lifelong, and pegylated interferon 180 microgram for 48 weeks. If patient has got fibrotic liver, again entecavir, TDF, TAF, and pegylated interferon dose remains the same and duration remains the same. In compensated cirrhosis, entecavir 0.5 milligram, TDF 300, and TAF 25 milligram, again lifelong. If this is decompensated cirrhosis, then you give entecavir in the dose of 1 milligram, you double the dose, or you give the TDF 300 milligram in lifelong. TAFE has not been recommended in the decompensated cirrhosis patients. If your patient is decompensated cirrhosis, assessment for liver transplant should be done. AVT improves liver function and survival in such patients. More than 80% transplant-free survival. Approximately 35% is delisted for liver transplantation, so they have got a good impact on that. Close monitoring for drugs tolerability. Rare side effects like lactic acidosis or kidney dysfunction are warranted in treating such patients. When to stop treatment, this is another important point of the management of treatment. Pegylated interferon has got defined duration of 48 weeks. Nucleoside and nucleotide analogs endpoint depends on the hepatic and HBE antigen status. If a patient is got cirrhotic liver, lifelong treatment is mandatory. If the patient has got fibrotic liver, again, lifelong treatment is mandatory. This is only when the patient has got normal liver when you can think about stopping the treatment. And again, it depends upon the HBE antigen status. In case of HBE antigen positive patients, you can stop the treatment who achieve stable HBE antigen seroconversion and undetectable HBV DNA and complete more than 12 months of consolidation therapy. Then you can think about stopping treatment in such patient. In HBE antigen negative patients who achieve long-term more than 3 years virological suppression, then you can think about the stopping of the treatment. But remember that close post NA monitoring is warranted in these patients. So, dear colleagues, I stop here. Today we discussed the treatment options, treatment, and when to start treatment, when to stop treatment, and what are the treatment options, what are the pros and cons of the oral therapy and the injectable therapies, and among the oral therapies, which drug to prescribe and which drugs to withhold. In the next video, we shall see how to monitor antiviral treatment when we start on treatment monitoring and the post-treatment monitoring. So, dear colleagues, we are reaching the end of the discussion on chronic hepatitis B, and I am sure that during these discussions, you may have become familiar with the applying these guidelines to your patients. You need to tailor the treatment according to each and every patient. You cannot treat all patients on the same levels. The patient's treatment needs to be tailored, and it needs to be individualized for each and every patient depending upon the liver status, viral load, the ALT levels, other risk factors, and other comorbid conditions. So I stop here, and inshallah in the next video we shall be discussing the monitoring of antiviral treatment. Till then, take care. Khuda Hafiz.